Okay, today we are going to discuss the most common of the colorectal cancers is carcinoma of the rectum. Globally, the carcinoma colorectal cancer is the second most common malignancy, affecting about 1 million people every year, and resulting in second most common cause of death. It is second most common after uh, common cause in men, and it is commonest, having 60% incidence of all colorectal cancers. Overall incidence is rising with an overall 14% increase since 1970, but with the largest increase, 20% is seen in males. Risk factors include diet, obesity, and lack of exercise. Risk factor, generally, the etiology and or the risk factor are the maybe the genetics, hereditary, non-polyposis, inflammatory bowel disease, post-surgical, and dietary. These are the risk factor. In among the genetic risk factor, the familial adenosis polyposis is the risk factor, accounting for about 1 to 2% of causing the carcinoma of the colorectal cancers, and after that is a Gardner syndrome, which is comprises of extra intestinal manifestations like osteoma of the mandible, epidermoid cyst, desmoid tumors, and congenital hypertrophy of the retinal pigmented epithelium. These have this Gardner syndrome also have the increased tendency of colorectal cancers, or the True syndrome, which comprise of intestinal polyposis, brain tumors like gliomas, and this is most commonly occurs in the first and second decade of life. Hereditary non-polyposis cancer, colonic cancers, is otherwise called as cancer family syndrome. It has overall 5% incidence of causing carcinoma of the colorectum. It is, if this is the cause, is the has the high occurrence of synchronous lesions. Synchronous lesions are the lesions, or the synchronous cancers are the cancers which they are defined as the cancers which are occurring at two places in the same organ. Like if there is a rectal cancers, and during our investigative workup, another cancer is also, or another malignant tumor is also found in the colon. Anywhere in the colon is known as synchronous. And other term is also used when you encounter in the clinical setting with these cancers, is the metachronous lesion. These metachronous lesions are, or the metachronous cancers are the cancers which are not detected on your investigative workup during your first investigations, and you operate the patient, or you treated the patient, and patient visit you with another lesion in the same organ after 6 months is known as metacarcinoma. So whenever we are dealing with the colonic or rectal cancer, we investigate for the synchronous lesion. As this synchronous lesion, if it is found, the strategy of treatment is changed. Abnormality of chromosome 17 and 18 is responsible in the hereditary non-polyposis cancer of the colon. Inflammatory bowel disease, among the inflammatory bowel disease is ulcerative colitis is more common cause of colonic or rectal cancers than the Crohn's disease. Ulcerative colitis has a tendency of converting in rectal cancer is about 5%, and Crohn's disease, if these this disease usually presents with the stricture formation, and when we treat these stricture, usually they are treated with strictureplasty. If um, colonic cancer is occurring in this Crohn's disease, it is usually the site of a stricture where strictureplasty was previously done or not treated this stricture. Post-surgical patients, they are the risk factor of the colorectal disease or rectal carcinomas in the ureterosigmoidostomy. In certain condition, when we divert the urinary system to the sigmoid colon, if the like carcinoma of the urinary bladder, if there is, and we form a new bladder with a sigmoid colon and ureters are open in this sigmoid colon, this is known as ureterosigmoidostomy. And this ureterosigmoidostomy can be a risk factor of developing carcinoma of the rectum. And there are incidents of colonic or rectal cancers in the patient who are previously had a cholecystectomy and the terminal ileum resections due to the bile coming to the site and stasis of that, and it transform the rectal carcinoma. Among the dietary factor, if a person is having low fiber diet and high fat diet, these are the risk factor of developing the rectal cancers. And the high fiber diet is preventive in the colorectal cancers. Immunosuppression, like post-irradiation, usually the cervical cancers, the patient, if they are treated with the radiation, they have the tendency of developing the carcinoma of rectum. HIV patients, solitary rectal ulcers patient. The solitary rectal ulcer previously we discussed, where they are present with the rectal prolapse or with associated with hemorrhoids or manual evacuation of the bowel. Repeatedly, these rectal ulcers develop and they may transform to rectal carcinoma. Adenoma. In previous our lecture, we discussed that adenoma of more than 2 centimeter have the higher tendency of developing the cancers. Villus adenoma is also having higher tendency of transforming into the rectal cancers. Age is also important as these patients of the colorectal cancer, they are usually more than 60 years or up to 70 years, and the multiple adenoma, if they are present, like familial adenosis polyposis, they have the tendency of developing cancers. And adenoma in elderly patient is also supposed to be causing the rectal cancers. Lifetime risk of colorectal carcinoma in first degree relatives is population risk is 1 in 50 as you take the whole population and you assess there are chances of developing rectal cancer in population is 1 in 50. If one relative is affected in the family, one among the 17 have the chances of developing carcinoma of rectum. If one first and one second degree relative is affected, 1 in 12 is the chances of developing carcinoma. If one relative less than 45 years is affected, there are chances of 1 in 10. If two first degree relative, 1 in 6. If dominant inheritance or pedigree, 1 in 2 is the chances, it mean 50% of chances of developing the carcinoma of rectum. Pathology or pathogenesis. Colorectal cancers originate from the pre-malignant precursors region in epithelial lining of the colon or rectum in stepwise progression that result in increase in dysplasia due to an accumulation of genetic abnormalities. In spontaneous colorectal cancers, as compared to the hereditary cancer, this is referred to as adenoma carcinoma sequence. Columnar epithelium from the columnar cell carcinoma or from the colonic epithelium, they transform to the with the repeated irritation or the other etiological factors, they convert to dysplasia and they goes to convert in the carcinoma of the rectum. May start as a benign adenoma and adenoma carcinoma sequence, as I told you. Usually it's these are slow growing. Neck of the polyp is the line between the normal adenomatous epithelium is the commonest site of the carcinomatous change. Types, if you see on a gross examination, they may be annular, ulcerative, or cauliflower. Annular mean stenosing. They cause these annular growths. They cause the intestinal obstruction, and these patients may present with the intestinal obstruction. If you examine your proctoscope or the finger DRE, you may feel an ulcer. These or the ulcerative growths. These are slow progressive, and cauliflower growths may also be found. Like they have the shape of cauliflower. Microscopic, they may be tubular, they may be villous or tubo-villous, or the mixed histological type. Tubular and villous, if mixed, is known as tubo-villous type. Usually, all cancers they grow locally, and they spread, they metastasize. They may be the local spread or the metastasis to the other organs. Okay, these annular growth, if we discuss this occupies this occupies the circumference of the lumen in 2 years. This encroaches whole lumen in 2 years, and mean if it is causing obstruction, mean the disease was started 2 years earlier. There may be the local spread. Within the local spread may be the radial, the circumferential. It causes uh, 1/4 of circumference is affected in 6 months. Mean it takes whole circumference to be involved in 2 years. Longitudinal, more in the proximal direction. This if it is spreading in the wall, and longitudinal spread is more on the proximal direction. Involvement of the adjacent anatomical structures, like if it is spreading anteriorly, it may cause the involvement of the urine bladder, prostate in the male, and the vagina and cervix and uterus in the female. Posteriorly, the sacrum and the sacral plexus. Laterally, if they are spreading, they can cause um, the involvement of the ureters and ureteric obstructions. There may be lymphatic spreads and the hematogenous. The lymphatic spread of the rectal mucosa communicate freely with those of the muscle layer. The usual drainage flow is upward, and only to a limited extent laterally and downward. For this reason, surgical clearance of malignant disease concentrates mainly on achieving the wider section of the proximal lymph nodes. However, if the usual upward routes are blocked, for example, by metastatic disease, the flow can reverse, and it is possible to find involved lymphatic on the side wall of the pelvis, along with middle rectal vessel, or even in the inguinal region, along with the inferior rectal vessels. Hematogenous spread, they usually involve the superior hemorrhoidal vein, then the upper half of the anal canal above the dentate line, pass upward, become the rectal, and hematogenous, they spread to the portal system, and they uh, causes the infiltrate in the liver metastasis is most common, then adrenals, and they may metastasize to the brain by the hematogenous route. We stage the disease whenever there is a malignant disease is encountered. We we stage these disease. There are certain system to stage. There are certain methods to stage the disease. Among the um, rectal cancers, Dukes is most commonly used. Duke's classification or Duke staging is done like A, B, C, and D. A, if it is limited to the rectal wall, mean if it is involving the mucosa up to the muscularis, is Duke's A. Extrarectal site, if it is involved, when serosa is breached, it is considered as Duke B. Regional lymphatics or lymph nodes are, if they are involved, it is known as Duke C, and C1 is pararectal or C2 along with the named vessels. If distance metastasis is there, it is considered as Duke D. Duke D is not originally involved in the Duke's classification or Duke's staging. It is modified Dukes in which we include the distant metastasis. Otherwise, Duke C up to Duke C is the origin, is the Duke's classification. Disadvantage of Duke's staging is histopathological grading is not taken under consideration. Alternative pathway is a modified Askler-Collin staging, which is considered. This is Duke's classification with overall survival rate, 5-year survival rate. If patient is in Duke's A, if they are treated, they have 5-year 90% survival rate. Duke B is 60, C is 30% overall, and C if there's C1 is 40% and C2 is 20%. And if there are distant metastases, the Dukes says that patient survives 5 years less than 10%. This is modified Askler-Collin classification, which denotes A, intramucosal lesion, B, spread up to the muscularis propria, B2 is spread through the serosa, C1 is primary bowel nodes, and C2 is primary beyond local infiltrate plus nodes. Adjacent organs are infiltrated plus lymph nodes are involved. Most accepted classification or staging is worldwide is done is TNM staging, which denotes T for tumor, N for node, and M for metastasis. T1 if submucosa is involved. T2 up to the muscularis propria. T3 up to serosa, non-peritonealized pericolic or perirectal tissue. T for through the serosa, perforation or direct involvement of the organs. N1 is pericolic or perirectal lymph nodes less than 3. N2 is pericolic or perirectal lymph node more than 3. M naught or no metastasis, and M1 is distant metastasis to the other sites like liver, adrenal, and brain. If you make a stage with this T and M, stage 1 is T1 and 2. Stage 2 is T3 and T4. If lymphatic involvement is there, along with any tumor, any T stage with lymphatic involvement is stage 3, and if there is distant metastasis along with any T and any N is stage 4. Overall survival rate according to the TNM classification is 70 to 90% 5-year survival rate in stage 1, 54 to 65% in stage 2, 40 to 60% in stage 3, and 1 to 6% in if patient comes with stage 4 disease. Clinical presentations: patient may present with the bleeding per rectum, which is after the defecation and fresh blood coming out of the anus. It usually have a differential diagnosis of the hemorrhoids. Complete examination is required, in which you can found the annular lesion or ulcerating and cauliflower. Usually the ulcerating lesion, these cause the bleeding per rectum. Tenesmus, as in earlier lecture, last lecture we discussed, tenesmus is the feeling of defecation, but the patient if goes to the toilet, there is nothing coming out. Patient have repeated reflexes of defecation. Altered bowel habits patient may present with the altered bowel habit. Pain is a late feature if it involves the adjacent organs, and weight loss is also a late feature. In abdominal examination, when patient is having a metastatic disease, you can find the ascites, presence of ascites, liver enlargement, and if patient is presenting with a stenosing lesion and with the intestinal obstruction, there would be the signs of intestinal obstruction on abdominal examination. Rectal examination will, in 90% of rectal cancers, the tumor are palpable on digital rectal examination, and they can be visualized on your proctoscopic examination. Mean features presenting as a elective case, or they may present as an emergency with intestinal obstruction. Investigations done is the proctosigmoidoscopy along with the biopsy, which confirms the type of histopathological type of the cancer. Barium enema can be done. Colonoscopy is performed. CT scan and endoluminal ultrasounds. These are the investigations. On proctosigmoidoscopy, you can say examine up to the sigmoid colon, and if there is any growth visualized, it can be biopsied in the outpatient department, and the biopsy is sent to the histopathologist for the confirmation of our diagnosis. If um, extensive assessment is required, mean whole colon has to be visualized for the synchronous lesions. Barium enema, colonoscopy, and CT scans are done. CT scan is also done for the local invasions, metastatic lesions, and the synchronous lesion examination. Ultrasound, endoluminal ultrasound give good assessment of involvement of the bowel wall or rectal wall. It can be performed in the patient with the colorectal or other rectal cancers. Differential diagnosis may be the benign adenoma. Larger adenoma should be suspected as a malignant and they should be biopsied. There may be the inflammatory strictures formation in the inflammatory bowel disease. Patient has a longer history of the altered bowel habits and bleeding per rectum, and biopsy confirms the inflammatory cause. MAB granuloma is another differential diagnosis in which patient has uh, growth like growth in the rectum, but it is a granuloma, and patient has a traveling history. Endometrioma is another differential diagnosis in which in this female patient, if the endometrial deposition is there, and these usually bleed during the menstrual cycles, or the solitary rectal ulcer should also be differentiated from the rectal carcinoma. As I told earlier, patient present with bleeding, tenesmus, altered bowel habit, pain, and weight loss. These are the things which, and obviously in the old age patient, if these are the presenting features, rectal examination will give a diagnosis or a clue of the diagnosis, and biopsy will confirm the diagnosis. Then you treat accordingly, as if patient has tumor in upper third of the rectum, anterior section of the rectum is done, in which continuity of the GI is restored. As in the anatomy section or surgical anatomy section of our previous discussion, we discussed that conventionally the rectum is divided into upper, middle, and lower third. Upper third is intraperitoneal, and if there is tumor in the upper third, there is possibility of restoration of continuity after surgery. The anterior section is the procedure. Anterior section means you perform the surgery through the abdomen and remove the tumor along with the lymphatics involved, and you restore the continuity of the GIT is the anterior section. If there is lower third of the rectum tumor, it involves the sphincters. There are chances of involvement of the sphincters, and there is no chance of restoration of the continuity, because patient will, after post surgery patient will have a fecal incontinence. So the AP resection or abdominoperineal resection of the rectum is done, in which we perform the whole excision of whole rectum and the anal canal, and will make the permanent colostomy, is known as an abdominoperineal resection of, of the rectum. APER is also term used abdominoperineal excision of rectum. Middle third tumor has both options. If it is possible to resect the tumor with 2 centimeter distal clear margin, as we discussed that the tumor usually spreads in the upward direction. Downward direction is rare. Mean downward spread is rare. If you have a healthy, clear margin up to 2 centimeter in a gross, and there is a sphincter is saved, you can do the low anal anastomosis, and anterior resection is possible. Or if 2 centimeter clear margin with preservation of the anal sphincters is not possible, we should perform the abdominoperineal excision of rectum. Patient present with the emergency setting, mean patient presents with the intestinal obstruction. We treat the patient as a intestinal obstruction patient, admit, hydrate, electrolyte replacement, antibiotic, painkiller, decompressions, and we do the laparotomy. In laparotomy, what we do, we excise the tumor. We don't know the status of other sites of the synchronous lesion, or the where synchronous lesions are possible, and this patient is not worked up properly for the radical surgery. What we do, we just remove the tumor, disease part, and we make a end colostomy. We close the rectal stump and we make the end colostomy for further workup. Patient, when he or she settles from the acute condition, we reassess the patient and perform the definitive procedures. After the treatment of surgical treatment of these patients, or before the surgical treatment of these patients, we have the option of neoadjuvant chemotherapy or the radiotherapy. In elective settings, we can coordinate with the oncologist for the neoadjuvant chemo or radiation to debulk the tumor, and possibility of restoration of anatomy. We can send the patient to the oncologist who decides either neoadjuvant will help or not. If he decides to give the neoadjuvant, radiotherapy or the chemotherapy starts with that, and after the completion of cycles of neoadjuvant oncological treatment, oncologist sends to the patient to the surgeon for the surgical excision, and the surgical treatment which I told earlier are these are the options which are decided by we surgeons. And after surgery, when we send the patient for the oncological treatment, is known as adjuvant treatment. If it is done before the surgery, is a new adjuvant, and if it is done after surgery, is the adjuvant. And the treatment is done is chemotherapy and or radiotherapy. Chemotherapy alone or along with the radiation and chemotherapy. In unfit patient, we have other options. Patient is having annular lesions and patient is unfit for surgery. We can we can introduce the stent to overcome the obstructive signs. There are intestinal stents are available, expandable stents, which can be placed to relieve the obstructions. Result of surgery is overall 5 years survival rate 50%, and it declines with the stage of the disease. If higher the stage and the result or the involvement of the lymphatics, if more is there is decline of the 5 year survival rate in these patients, or prognosis is worse in the advanced disease. Thank you very much. If you have a question, you can send in chat or you can ask the question. जी कोई क्वेश्चन है तो पूछिए. No question? Okay, thank you very much.